Today I would like to introduce the present status and problems of clinical practice guidelines, which include recommendation on acupuncture in Japan. It will be informative and useful also for the delegates of the other countries. I have no conflict of interest in this presentation. Recommendation on treatments in clinical practice guidelines are decided based on not only the body of evidence, but also consideration on benefit-harm balance, accessibility, cost, consistency, generalizability, applicability, patient preferences, and so on. So it is said to be important to have guideline drafts reviewed by outside experts and members of the public. In Japan, unlike Korea and China, there are no evidence-based clinical practice guidelines which focus only on acupuncture so far. Academic societies of acupuncture have been considering to develop and publish such guidelines, but it is still at concept stage. So what I'm going to speak today is about clinical practice guidelines which were developed and published by academic societies of modern Western medicine. Japanese clinical practice guidelines, which list grade of recommendation on acupuncture as well as usual care options, have been published in recent years. Some guidelines recommendations seem to be based on good quality clinical evidence, such as systematic review and meta-analysis of well-conducted randomized control trial, and adhere to predefined assessment procedure. However, there are also low-quality guidelines. As of September this year, 13 guidelines, including recommendation on acupuncture, have been published. Tennis elbow, cystitis, facial palsy, OPLL, toothache, headache, IBS, cervical myelopathy, overactive bladder, pregnancy and delivery, alopecia areata, fibromyalgia, and low back pain. We assessed whether or not each recommendation on acupuncture is fair based on existing evidence and guidelines definition. Recommendation of acupuncture for facial palsy, tension type headache, IBS, and alopecia areata are undervalued. Recommendation and evidence on low back pain are based on some serious errors of data analysis. On the other hand, acupuncture is overvalued in guidelines of tennis elbow because it is based on conclusion of very old version of Cochrane systematic review, but in this September, the 2019 version has been published, and I have not read that yet. For acute facial palsy, acupuncture is graded as C2, which means that they cannot recommend this therapy because there is no evidence. However, there is evidence, although the quality of the relevant randomized control trials is low. So instead of C2, it would be graded as C1, which means we may consider acupuncture based on not enough evidence. For irritable bowel syndrome, acupuncture as alternative therapies is recommended against, based on low level of evidence. However, no serious harm has been observed so far, so instead of recommend against, it should be at least propose against, which is one grade up. Acupuncture is graded as C for tension type headache, which means not enough evidence to recommend to use. However, the Cochrane review concludes that acupuncture is suggested to be effective for treating frequent episodic or chronic tension type headaches. So instead of C, acupuncture should be graded as B, which means recommended. As for alopecia areata, in 2010 version, acupuncture was graded as D, which means recommended against, based on good quality evidence on ineffectiveness or harm. However, actually there's no good quality evidence on ineffectiveness or harm of acupuncture in treating alopecia areata. So this clinical practice guideline was self-contradictory. This wrong information was reported in a highly influential domestic newspaper, and it made Japanese people get the wrong idea about acupuncture for alopecia areata. The Japan Society of Acupuncture and Moxibustion sent a letter to the Guideline Development Committee of this clinical practice guidelines and pointed out the inappropriate decision based on self-contradiction with their definition. I'm not sure they consider the opinion of the society's letter, but anyway, the 2017 version changed the grade from D to C2, which means should not, because of no evidence of acupuncture in Japan. And I myself think it's still undervalued. For low back pain, once acupuncture was graded as B, which means they recommended it for low back pain. However, the 2019 version has changed alternative therapies, including acupuncture, as no recommendation. Such a classification does not exist in the definition of this guideline. They state they conducted a meta-analysis on their own and found no superiority of acupuncture on pain and disability. However, when we take a closer look at the forest plot, we can find serious errors. In the RCT paper by Hasegawa and colleagues, the data used were actual measured value of visual analog scale of pain, which means the higher, the more painful. On the other hand, in the RCT paper by Shin and colleagues, the data are changed from baseline of numerical rating scale of pain, which means the lower, the more painful. So they mixed these data of opposite direction of the scale together, and consequently the combined data show no significant difference. This is an elementary and a serious mistake. If we put the corrected data in, the forest plot shows acupuncture superior to control. However, we usually do not mix these two RCTs because the control group is very different. One is the intramuscular injection of diclofenac, and the other is non-penetrating shunt needling. The same kind of errors are seen in meta-analysis of function, and we could also find errors in data extraction. As for chronic low back pain, based on their own meta-analysis, the guidelines state that they found no superiority of acupuncture for pain. However, when we take a closer look at the RCT papers selected, one is certainly on acupuncture, but the others are laser acupuncture, auricular point acupressure with botanical Cs, and acupressure backrest. So this is not a meta-analysis of needle acupuncture. Also, we found many errors in data extraction and input. In principle, systematic review teams should be independent from the guideline development group, expert opinion should be considered, and the draft should be reviewed by an external evaluation committee. But the present clinical practice guidelines on low back pain followed none of these principles. Because there are too many serious errors which cannot be shown completely here today, we published a peer-reviewed commentary article in a domestic journal pointing out all the errors and inappropriate procedure of development of the guidelines. So, what about your country? As all of you may know, a clinical practice guideline from American College of Physicians strongly recommends some non-pharmacologic treatment, including acupuncture, for acute or subacute low back pain with low quality evidence, and chronic low back pain with moderate quality evidence. On the other hand, NICE guideline in the UK has changed the recommendation from consider in 2009 to do not offer in 2016. According to an interview article of The Guardian, this change was because there is not enough evidence to show that it is more effective than sham treatment. So, including but not limited to Japan, the knowledge that sham needling is very different from inert placebo pill may not be well recognized in the field of healthcare. Therefore, we should keep on saying that sham acupuncture is not inert, but active and effective to some extent. So this is summary. Especially I would like to stress that clinical practice guidelines, including information on acupuncture, should be reviewed periodically. Thank you very much for listening. That's all.